Okay, I'm going to do a very brief description of airway pressure release ventilation, or APRV. We decided to do this based upon the discussion board and Blackboard Collaborate because several people in the class don't have experience with APRV, so we decided to do this to see if it would be beneficial for them. So first of all, APRV, which has been around for many years, is basically allowing a patient to breathe at two different levels of CPAP. We have a PEEP high and a PEEP low. We also can set a time high and a time low. And theoretically, at least, the patient is allowed to breathe spontaneously at each level of CPAP. However, usually by most people's algorithm that they use for APRV, the time low is so short there's not enough time for the patient to breathe spontaneously. So really the patient is allowed to breathe spontaneously at a high level of pressure, which we call P high, and hopefully it'll allow recruitment of alveoli, as we'll see in a few minutes. Initially, this is designed for use for patients that are intubated. However, some people are beginning to use it for non-invasive ventilation as well. It can be partial ventilatory support, which is the primary way that it's used, or it can be full ventilatory support if the patient is heavily sedated, anesthetized, or paralyzed, which some people will do for the first 24 to 48 hours of ventilation, even with APRV. This is a slide from Habashi's article from Critical Care Medicine that was assigned for this week. You can see that in this large phase here, this is P high, and it has a pressure high that's set at about 18 centimeters of water. This is a pressure being graphed on the y-axis, time being graphed on the x-axis. If you look at the lower waveform, we have flow being graphed on the y-axis and time being graphed on the x-axis. Again, looking at the pressure waveform, the patient is allowed to breathe spontaneously, and you can see that the pressure drops down here slightly as the patient inspires, which corresponds down here on the flow versus time waveform of a inspiratory effort followed by an expiratory effort. And if you notice up on the pressure again, the airway pressure goes up slightly during exhalation. This is very common. So during P high, the patient's allowed to breathe in and out, breathe in and out, and again you can see these during inspiration and expiration, inspiration and expiration. However, periodically at a preset time interval, the pressure drops from this P high down to a P low that is usually set at 0. When that pressure drops from P high to P low, you see an expiratory flow here. Then the patient's expiratory flow gradually decreases until time low ends. When time low ends, pressure immediately goes back up to P high, or pressure high. These intermittent periods where the pressure is released is called the release pressure, or the release point, and it results in a exhalation of a given tidal volume. The tidal volume is variable based upon the delta P from P high to P low, based upon the patient's expiratory time constant, the resistance times the compliance, as well as the resistance applied by the exhalation valve. This is an article that came from the Cleveland Clinic Journal of Medicine, and they evaluated many different articles that had described APRV, and they feel that the physiologic effects of APRV are that it does improve oxygenation, it does result in a reduction in sedation as opposed to traditional volume assist control ventilation or volume control or pressure control ventilation. Patients generally have an improved hemodynamics, probably due to the improved venous return with the spontaneous breathing at P high, and there's improved respiratory mechanics generally and increase in compliance from alveolar recruitment. However, there was no reduction in mortality. This was an article by Roy and Habashi. They used APRV in pigs and they created sepsis with a reperfusion induced ARDS, and in this group of 7 pigs, 4 of them had APRV, 3 of them did not, and the 4 that had APRV did not develop ARDS. Some people are very excited about this article. However, I think we need to be a little careful. It's a very small N. It's in pigs. We're not real sure if that same information translates to humans. So some of the advantages of APRV is we control the airway pressure. We're able to elevate the mean airway pressure, and by elevating the mean airway pressure, it results in an increase in FRC and a reduction in atelectasis. But even though we've increased the mean airway pressure and we're ventilating at a P high level, still the peak inspiratory pressure is lower than what is traditionally seen with volume AC or pressure AC. Also, with APRV, we allow the patient to breathe spontaneously. That spontaneous breathing helps to enhance venous return. It improves the VQ by also improving the ventilation to the gravity-dependent areas of the lung. Generally, APRV will improve oxygenation by alveolar recruitment and by improvement of the VQ. In pigs, as I said on the previous slide, it may prevent the progression to ARDS in these reperfusion-induced ARDS pigs. Some of the disadvantages of APRV can be significant. First of all, the tidal volume is variable. It is not possible to limit the tidal volume directly. We can limit the tidal volume indirectly by limiting the delta P, going from P high to P low, and by limiting the time low. Some people feel there's an increased work of breathing of the patient breathing at PEEP high. Other people feel that we can reduce that work of breathing by using automatic tube compensation. Jeff has talked a lot about transpulmonary pressure in the first half of the semester, and one of the concerns that people have about APRV is the effect on transpulmonary pressure. If we're ventilating a patient at a P high of, say, 25 centimeters of water, and the patient is allowed to breathe in spontaneously, let's assume that their pleural pressure is a -7. The transpulmonary pressure is the alveolar pressure minus the pleural pressure. If the alveolar pressure is 25 and the pleural pressure is a -7, then our formula would be 25 minus a -7, or 25 plus 7, and our transpulmonary pressure would be 32. Some patients in APRV appear to have a very strong inspiratory effort, and there is significant concern by some people that the transpulmonary pressure may be very high. Another concern that is expressed is the tidal volumes. As we know, they are variable, but they may be very large, and in fact the tidal volumes may be much larger than the 4 to 6 mils per kilo that the ARDS net protocol would like us to stay within. There's also some evidence to show that if we allow the patient to breathe spontaneously early on in ARDS, we may actually worsen the clinical stability and prolong ventilator days. Another problem with APRV, I believe, is the availability of APRV. APRV, as we'll talk about a little bit later, is not the same thing as biphasic, is not the same thing as bivent. I think there is a difference between the different ventilators, the way that it actually applies the pressure release, the fixed T high, the fixed T low in patients. One of the most significant issues I think that we need to be careful of is the lack of availability of clinical evidence. We have some evidence to show that it is beneficial, as we said previously, in improving oxygenation, in improving hemodynamic function, but we have very little evidence showing that it reduces mortality. The initial ventilator settings that I've used here are from Habashi's article on critical care medicine from 2005. Even though that article is rather dated, it is still, I think, the best article on a very good prescriptive description of APRV. Dr. Habashi recommends starting with a P high of 20 to 25 centimeters of water. If the patient was previously ventilating in volume targeted ventilation, then you can set the P high equal to the plateau pressure, or if the patient was being ventilated in pressure control ventilation, some people will set the P high equal to the PIP in pressure control ventilation. The time high usually is set at 4 to 6 seconds. Generally, you want the 90% of the total time to be equal to the time high. This means that if you take the time high and divide it by the time high plus time low, that should be equal to about 90%. For example, if you had a time high of 5 seconds and a time low of 0.6 seconds, that would give you a percent of total time of 89%, which would be an initial appropriate starting level. P low is usually set at 0 centimeters of water. This is to allow a larger delta P when we go from P high to P low, which aids in exhalation of volume, CO2 removal, and allows the patient to exhale more easily. The time low is usually set at 0.4 to 0.8 seconds. 0.5 or 0.6 is probably a good average starting. However, we want to set the time low at a level, at a point where time low will stop when the expiratory flow is 75 to 85% of the peak expiratory flow, and I'll explain that a little bit better in a subsequent slide, or I can show you this on a graph. Dr. Habashi believes in using ATC at 100% set for the proper size of ET tube. This is to reduce the work of breathing of the ET tube and provide some support to the patient, but still allow the patient to breathe in a spontaneous sinusoidal flow waveform. This is a tracing from the Draeger V500. The patient's being ventilated right now in APRV, and you can see that I have frozen the screen and we have exported this using the export function from the Draeger. It's a very nice function, and I'm showing right here the peak expiratory flow rate. So you freeze the screen and you can measure the peak expiratory flow rate. That is our peak expiratory flow rate, and if you look over here, it displays a numeric value of our peak expiratory flow. Then you can scroll across on the screen and you can measure the point at which the ventilator switches from time low to P high, and this is the point that I would select, and that point the flow is about 28.7 liters per minute. So the percentage at this point is 28.7 divided by 59.9, or about 48%. So if this were a patient, since usually we're going to shoot for 75 to 85%, we would want to shorten T low so that T low would be stopping somewhere back here, and we would turn it down usually 1/10 or 0.1 or 0.05 seconds at a time until we're able to reach approximately 75 to 85% of the peak expiratory flow rate. When we're ventilating patients with APRV, if their PCO2 is elevated, we have several different ways to reduce the PCO2. Obviously, if we're going to reduce the CO2, we either have to reduce the CO2 being produced, or we have to increase alveolar ventilation. One method of increasing alveolar ventilation is to increase the delta P. We can increase the delta P by increasing the PEEP high. However, we have to be careful and remember our transpulmonary pressure, and we probably in most cases do not want to exceed about 25 to 27 centimeters of water. Another way to increase the delta P would be to decrease the P low if P low was set at a value greater than 0. However, remember with Dr. Habashi's protocol, he always sets the P low at 0, so this wouldn't be an option. Another method of altering the PaCO2 is to change the T high. However, this gets a little bit more confusing and it is not quite as intuitive. If the patient is not breathing spontaneously, so this is a patient that's heavily sedated, anesthetized, or paralyzed, we can increase the minute ventilation by decreasing time high. That will allow more releases, which will increase the minute ventilation, and it should decrease the CO2. However, as we decrease the time high, we will spend less time at time high, it will drop the mean airway pressure, and it may decrease the overall surface area of the lung, so we have to be very careful. Generally, we will only decrease the time high if the patient is not breathing spontaneously. If the patient is breathing spontaneously, we can increase the alveolar ventilation by increasing time high, which is the opposite for a patient who is not breathing spontaneously. If the patient's breathing spontaneously and we increase time high, we will increase the mean airway pressure. If we increase the mean airway pressure, we hope to recruit more alveoli and increase the surface area of the alveolar capillary membrane, which will increase the alveolar ventilation. So to review that, we can change the time high two different ways. If the patient's not breathing spontaneously, we may need to decrease the time high to allow more releases. If the patient is breathing spontaneously, we may want to increase the alveolar ventilation by increasing the time high to increase the mean airway pressure, recruit more alveoli, and increase the surface area of the alveolar capillary membrane. Another way to decrease the CO2 is to increase the time low. As you increase time low, the patient will exhale more volume. However, you need to be careful because the more you increase time low, the more likely you are to cause derecruitment. So you should probably stay with the expiratory flow, the flow during time low, equal to 75 to 85% of the peak expiratory flow. When we want to improve oxygenation, generally we want to increase the mean airway pressure. We can increase the mean airway pressure by increasing PEEP high, but we have to be careful again and not go too high. Remember to consider your transpulmonary pressure. We can also increase the time high. This will also increase our mean airway pressure. We can decrease the time low. However, even though that will increase the mean airway pressure, it may reduce the release volumes and increase the PCO2. with P low, since it's usually set at 0, we're not going to change it. We can wean patients with APRV after they've stabilized, after their oxygenation is improved. We've been able to reduce the FiO2 usually down to about 0.4. The phrase that you will frequently hear used is stretch and drop. Stretch means to stretch or increase the time high. Drop means to drop or decrease the P high. Typically, we'll increase the time high by about 1 second and decrease the pressure high by 1 to 2 centimeters of water to maintain a relatively constant mean airway pressure. However, if while doing this, if the patient's spontaneous respiratory rate increases generally by 10 breaths per minute, or the minute ventilation decreases by 3 liters per minute, you may need to consider returning to the previous settings. Once the P high has been reduced down to 10 centimeters of water, you should be able to change the patient over to CPAP of 10 and continue with the spontaneous breathing trial. So one of the things that I've talked about previously is the evidence and the lack thereof. When you go to clinicaltrials.gov and search for APRV or APRV and ARDS, you will find a few studies that are currently recruiting patients. This study, APRV compared to ARDS net ventilation, is from University of Tennessee at Chattanooga. The primary outcome measures are all-cause mortality. Time frame is 28 days or prior to hospital discharge. That's a primary outcome that they're evaluating, which is a very important one. Secondary outcome measures are number of free days and length of ICU stay and or total hospital days. This is to me a very exciting study. Like I say, they are currently recruiting patients, and I hope that within the next few years that we're going to see the results of this, and it'll give us some answers as to whether or not APRV does reduce mortality in patients with ARDS. However, realize that they are just recruiting patients now, so they will have to recruit the patients, get enough patients to have a large enough N, be able to finish the study, analyze the results, and get it published. We're looking at a couple of years probably before we see the results. There are other trials that are underway now that are currently recruiting patients. However, the primary outcomes for those are looking at oxygenation, sedation, and inflammatory mediators. While these are important, I'm surprised that none of those include a primary outcome of mortality. So what's the future of APRV? I think that we need to watch the literature closely. There will be increasing literature coming out regarding APRV. It's important for us to evaluate those published articles. We need to determine whether or not the article was a good article, whether or not the N was adequate, whether or not there's evidence based upon that article, and whether or not our patients should be treated in that way. If you're going to begin using APRV and you're not currently using it, I strongly suggest that you consult with some experienced clinicians first. I think that many of us are very familiar with volume AC, pressure AC, PRVC AC, CPAP, pressure support, etc. And a lot of ventilation is rather intuitive. However, to me at least, ventilating patients with APRV is not something that's intuitive. It's something that I've spent a lot of time talking to people, talking to experts, working with it clinically, and spent a lot of time reading about it. And I really think that if you're going to start using it, you need to have someone that you can talk to consult about the patients. I also think that even though ventilators have different modes on them that may appear similar, like bilevel and bivent, I honestly do not feel that bilevel, bivent, and APRV are the same thing. I think that applying those different modes on different ventilators will have a different effect on patients. I think the patient's response will be very different, and I'm not convinced that they really are the same mode. So those are some of my thoughts. I would encourage you to join our Collaborate session and discussion sessions, and let's chat about this. I look forward to seeing all of you on Tuesday. Thank you very much. Let me know if you have any questions. Bye-bye.